Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Kevin and Paul. How are you guys doing this morning?
Doing terrific. Good to see you, Dennis. Good to see you, Paul.
Hey, you too, Kevin. Great to see you again, Dennis.
So this morning, I'd like to talk about Versed, but before we get into this, Paul, you had mentioned you had a question about patient positioning.
Yeah, here's some basic stuff that I've been thinking about over the past, weeks, months, years. A lot of times when we're doing a procedural sedation, which we're going to be kind of talking about today with Versed and the whole reason for this podcast, but I wanted to talk about patient positioning and then ask a question. So a lot of times we go in and we do our MPT rotation. We're seeing ideal situations and environments in an OR, and the anesthesiologist, the CRNA, will put the patient flat on the back. And oftentimes they're doing procedures, in an open belly or laparoscopically, whatever it may be. And I think what happens is we see that, and that's what right looks like. And we get out into the field and we'll lay that patient flat on their back. And this is, at the time, maybe they don't have any airway issues. They're talking, they're protecting their own airway. But then when we go into procedural sedation, we're dropping their RAS down so that they're not as aware, they're not as able to protect their airway, and we still keep them flat on their back. And so I was like, why don't we just put them in a recovery position as long as we can, reach the limb or whatever we're doing procedurally. So what do you think about that, Kevin? Is that something that's viable for us in the field?
Yeah, so yes, absolutely. I would say as long as the position that you have the patient in is one that you can perform, whatever procedure you're trying to perform, if that's, if you're going to put that person in the recumbent position, whether it's the left side or the right side or even head up, I would say is if it works, great. If it doesn't work, just, do something different. I would say that typically, for example, we do sedations in the operating room in the prone position, right? So Somebody might have a lipoma on their back or some other type of procedure where we don't necessarily have to perform a general anesthetic. We wheel the patient in on the OR or on the transport gurney. We tell them to, flip them over like a pancake, and they're in like a Superman flying position. And we tell them to get comfortable. We position their head to the side and we put oxygen on them, and then we start giving them the sedative medications. What I always try to impress upon especially our learners that are coming through the OR, whether it's the SOCM guys or the CRNA folks that are there, or the PA students or whoever FP docs that come through and do an anesthesia rotation, you just have to have a plan if you do lose that airway in that position. Right. So whatever that plan is, just know what it is ahead of time, because it happens. Like you might have to, bag valve mask somebody in the prone position, and it's not easy. But if you do have to take an airway, just have a plan for, flipping that person back over into the supine position to where you can easily get to the airway. So we do sedations in weird positions and they work fine,
yes,
but just have a plan for if you do need to perform an airway maneuver. How are you going to accomplish that in that position that they're currently in, or are you going to have to flip them over into a more optimal position to perform that airway maneuver? That's really, so yeah, go for it. If it works, great. Yeah. If it doesn't, do something different.
I know for us, like you do 100 trauma lanes, I would say 0.0% of the time will you ever see a patient in a lateral recumbent position in the recovery position. But to me, it's making more and more sense, realizing the limitations of the tools that I have at my disposal out there.
Now, the one thing I will say that I see when you put them in a lateral position is, depending upon their volume status, it does change the return to the heart, right?
Sure.
So if you're putting them, left side down, that right atrium is now up. And there's not, and you can see a drop in blood pressure, and we've seen that where I've taken care of patients where you have to do like a dressing change, and you have to put them in this one certain position because that's what you have to do, and you turn them and you immediately see a significant decrease in blood pressure. You know it's coming. We'll typically give them some sort of vasopressor prior to that position change. To get their blood pressure up. So when we turn them, they tolerate it. And then we very quickly do that dressing change and then try to flip them back prior to that running out of that vasopressor medication that we've given. So once again, it's all about, did they tolerate that position? Do their hemodynamics tolerate that position? Is it optimal for their airway? Great, go for it. If they don't tolerate it, all right, well, you got to figure something else out.
Yeah, perfect. I appreciate it.
In something like that, like you mentioned, planning, this last podcast we did on the tactical timeout, that would be the time where, hey, we're going to do this thing. We are pretty confident this consequence is going to happen. So let's make sure we have not just the gear for the dressing change or whatever it is. Let's have our plans for a rescue. You're going to be at the head. You're going to be at the shoulders. You're going to be at the feet.
Right. Yeah. Usually predetermining. And that's what I usually will tell when I go into the OR and I have a patient that we're flipping prone. One of the things I will always say, I'm like, your job is to go get the bed. Because once we flip them onto the operating room table, we need to get that gurney back in there to flip them back supine. It's a lot easier to do that than it is to try to do like on the operating room table.
Yeah.
So like you're doing that, you're doing this, you're doing that. And then it's when it happens, you just like press the button and everybody just goes and does what they're supposed to do. The other thing that I would say, and once again, this is not so much in a normal volemic patient, like if you're just trying to reduce a fracture or in the lower extremity or whatever it is, and you're putting somebody in a recumbent position. But in a hypovolemic patient, when there is physiological consequences to blood flow to your lungs. Mm-hmm. So when you put somebody in a left lateral or a right lateral, let's just talk about left lateral. The right lung is preferentially ventilated and the left lung is preferentially perfused. So if you do have somebody that's like significantly hypovolemic, that right lung that's getting preferentially ventilated might not see any of the cardiac output, where that left lung might see it all, but it's not getting a lot of ventilation. So there are physiological consequences to putting people in different positions. So just knowing that ahead of time that they might not tolerate it, you just have to flip them back.
Yep. Nice. And I think, at least for the procedures that I foresee myself doing, I'm not doing a laparotomy. I'm not putting in shunts, anything like the heroic feats that your job used to be doing, right? Mm-hmm. So there's, at least to me, none of the procedures that I would be doing, I need to do it now. Like nobody is desperate to have a debridement now.
Right. Understand.
So we take the time, stabilize the patient, make sure that they're in the best, optimal for what we can do in the time we have. And just realize that, any of the procedures that we can do, we can stop. We don't have to do this. Even if it's like the worst mangled limb that we know we have to take off or do whatever we need to do, I can fix any problem with a tourniquet.
Yeah.
You know what I mean? And then get him resuscitated and then continue, finishing the job that needs to be done. So we're in no rush to jump headlong into a catastrophic situation.
Yeah, that's a fair statement.
The thing that made me really think of that is watching guys try to do even a minor debridement on the back of the calf, and now they're holding the leg up in this awkward position and putting it on their shoulder. And I'm like, guys, we can just probably turn them on their side for the next 30 minutes, 40 minutes while you guys do this, and it'll be okay. And that was kind of mind blowing because we always lay patients on their back.
Yeah, and I mean, you could even, once again, depending upon where you're at, like if I mean, you could put them in a prone position,
Yeah.
and it's once again, just have a plan for when things go sideways, and be like, okay, we're just flipping them back, and we'll continue on.
Yeah. Yeah. All right. So, jumping back into Versed. So, I don't have enormous amount of experience, which is why I asked you, Kevin, to come on, and you as well, Paul. You have a lot of experience in very austere, very dynamic environments. So I think you have the right perspective for what we need out of it. But if you wouldn't mind, just to make sure everybody's caught up to speed, could you give me some just basic background information about Versed?
Yeah. So Versed being a benzodiazepine, it is what we would consider a GABA agonist. It works on the GABA receptor. So they call it an allosteric modulator of the GABA receptor. So it doesn't necessarily act the same way that GABA does. What it does is it in a roundabout way of saying this is it kind of just promotes GABA agonizing the GABA receptor to allow chloride, which has a negative charge, to enter the CNS, whatever neuron is working on, and it hyperpolarizes that. So, and that's just basically how midazolam and other benzodiazepines work. So what I always try to, in my mind, I always have to go back to I know what the receptor is, I know how it works. You get into the weeds with that, but the question you always have to ask yourself is, where is that receptor? So that receptor is in the limbic system, right? It's in the midbrain. So then you have to ask yourself, all right, so what does the limbic system do? I'm not a neurobiologist by any means, and I have buddies that would probably cringe. It's like, you didn't explain it well enough, but it has to do with memory, long-term memory, in that area of the brain. So that's where I believe a lot of the majority of your GABA receptors are. So if you just very quickly take a step back, you go, okay, so it's a benzodiazepine, works on the GABA receptor. Where is the GABA receptor? And then what does the GABA receptor do when you agonize it? And then go from there. So that's just kind of the quick down dirty of what, specifically speaking of, we'll just talk about midazolam, but that's what it does. So you get anxiolysis, you can get amnesia with certain ones, you can get a decrease in your sympathetic nervous system response. It's just you can get a sympathectomy. So that's kind of the things you see.
Okay. Speaking of amnesia. Now, from what just book knowledge, I don't know if there's a great big difference, but with Versed versus diazepam, Versed gives you antegrade, which means from that moment going forward, versus diazepam, you get retrograde. Is there a real difference?
Well, I to be honest with you, I've not read that. I've not read that diazepam causes retrograde amnesia. I would have to go back and look at that one. I'm more into the weeds with midazolam because that's a medication that I use all the time. But yeah, so midazolam is when you give it, that's when the amnestic properties start and they move forward. It's not going to make you not remember 20 minutes ago. Like, you will have full recollection of whatever events happened up until I give you that dose of midazolam. Now diazepam, I've never really looked at that medication as something that even causes amnesia. I've seen it more as an anxiolytic medicine. Now, I would assume that's very much dose dependent, but diazepam is just not something volume. It's just not something, a drug that I've used a ton in the anesthetic world. We usually will give it for just muscle spasms after surgery. That's typically what we give it for.
Yep. So what about dosings? Let's start with just normal healthy guy. What is a normal dose range versus somebody who is sick?
Sick. So the book answer is 0.01 to 0.1 mgs per kg is kind of the sedation dose. That's the book answer. So what I would say is, if you actually look at a 100-kilo guy, I have never given a sedative dose of 10 milligrams of Versed. I just have never done it. That is a big dose, in my opinion. That's where the induction dose starts in the book. It's usually 0.1 to, I think, 0.4, where typically the dose ranges that I am living in, for the most part, in the hospital is 2 milligrams. And or sometimes with neuro patients, where you're going to go do a neuro case for whatever reason, where I trained, it was 5 milligrams. It just seemed like if you were getting some sort of debulking of a brain tumor, you're getting 5 milligrams, and if you were just going back for an orthopedic procedure, you're getting 2 milligrams. So I usually live in the 2 milligram range. I usually don't go more than that. Just prior to surgery as an anxiolytic type drug. Also, if we're going to do a peripheral nerve block, going ahead and giving 2 of Versed to just about everybody that gets a peripheral nerve block. And typically you'll talk to them, like they'll watch the ultrasound screen, but they just have no recollection they just don't remember it. Yeah. So even in a normal volemic, well, I guess everybody at Fort Liberty is dehydrated during the summer. But typically 2 milligrams makes just about everybody that I come in contact with in the hospital amnestic of getting a block. Okay. Or that short trip back to the operating room where they're just getting slid over to the bed. You're talking to them, and they usually will say the same thing. They're like, I don't remember being awake for this part last time. And you're like, well, you're probably not going to remember this time either. Right. So,
now, how do those dosings change when you're talking about somebody, a trauma patient or just a very sick patient, where you're really thinking about cutting your doses?
Yeah, so everything is dose dependent, and it is also dependent upon the scenario that you're using it in. So in a hypovolemic trauma patient that you are, let's say, you're trying to get them off to sleep, the amount of medicines you're giving is so decreased that my anxiety is that they're remembering what I'm doing. So I might go, man, 1 milligram of Versed is all I'm comfortable of giving this trauma patient while I'm, trying to get an ET tube in, along with, a smaller dose of ketamine. So it might be 1 milligram of Versed and 30 of ketamine. And that's just probably where the smallest amount that I would go. And that's just typically because that's what's in the syringe that I draw up prior to trauma cases, especially downrange. That's just what I have. So like 1 cc of my Tiva stick, as we call it, is 1 milligram of Versed, 30 of ketamine, and it's got 25 mics of fentanyl in there. Okay. So, and even that sometimes could be too much. Yeah. So it all depends. Like if somebody is, if I'm looking at a heart rate of 140s and I've got a systolic that's, less than, in the 80s, a cc is about as much as they're going to get. And in that cc is 1 milligram of Versed. Okay. Now, if somebody has a broken femur and otherwise hemodynamically stable, that's a different story. Like if I'm downrange and I'm using my Tiva stick to get them off to sleep, that's probably half of what I am going. It's going to be 3 to 5 cc's, which is anywhere from 150 of ketamine to 3 milligrams to 5 milligrams of Versed, along with 125 mics of fentanyl. But that's somebody who is much different than a shot in the box who's hypovolemic. So that's somebody they've got a femur fracture. Okay, yeah. We got to get this guy off to sleep so they can, either put an X-fix on it or do or reduce it or whatever they need to do.
Yeah.
Hey, so Kevin, is this where you're personal experience, your gestalt comes in, or are you doing calculations and looking at, shock indexes and all this other stuff, or is it just kind of the art of medicine at that point?
I think you're definitely correct on the art of medicine. I think, looking at shock indexes and trying to compute all of that in that scenario. Like I always tell people, if you're doing math don't do math in public, but you shouldn't be don't do math when you're under duress. Yeah. Just don't do math. I think that's like a gut feeling. That's looking at somebody going, this guy is about to lose their vital signs. Like we are about to be in PEA. And sometimes even then what we used to do, and I think the last batch expired in 2015, is we had scopolamine, IV scopolamine. And it was then, like back prior to 2015, like you would give a cc of that, and I believe it was 0.4 milligrams, and in hopes that would scramble a hypovolemic patient's brain enough to where they're not going to remember you intubating them and the first incision, and then you could get caught up with resuscitation and then start giving them other amnestic type medications, whether it's gas that we use or Versed and ketamine.
Yeah. I know if Sean Keenan's listening, he's probably going to lose his mind when we're talking about mixing drugs in single containers like bags and sticks.
Oh, yes.
But I understand that you guys have so much more experience doing that. You do it on a daily basis. Then you go down range, you train for that. That's exactly what you're doing. So we have to be careful on our side telling a medic, hey, put 3 drugs in a stick and then go ahead and push that. Now, I think you could probably get away with other things like start low, go slow, and that. But what are your thoughts on that?
I agree with. We are polypharmacists by trade. That's what we do. We combine lots of different medicines, and we do it on a daily basis. I do not teach that method of combining the Versed, ketamine, and fentanyl in a syringe to anybody other than other nurse anesthetists and anesthesiologists that go down range that ask me like, hey, what do you do? I'm like, hey, this is what I do. And they are very comfortable typically with that type of mixture because we know how these all typically work, and they giving them all at the same time. So if you're not going to have Versed, ketamine, and fentanyl in a single syringe, I would say it's reasonable that if you have, your 10 milligram per cc of ketamine in a syringe, like if you've diluted it out, and then you have your milligram per cc of midazolam in a separate syringe, I typically will go ahead and give the Versed first, a milligram. And then I'm pushing that in with the ketamine, right? So then I'll give the 2 or 3 cc's or more of ketamine, but at least I've kind of pushed in that potential amnestic dose of Versed first. So that way I can provide amnesia before I do anything else, which is typically how we induce patients in the OR. The first drug that we typically give is propofol, which produces amnesia. And then we push everything else. Well, I shouldn't say that. We do give narcotic first because it just takes a little bit longer, the onset, than propofol. And we're trying to intersect the amnesia along with the analgesia while we're, putting a tube in someone.
Yep.
Sure.
So correct. So I'm sorry, just to go back, the only time that what I do teach, and I think the last podcast I did with you, Dennis, was our Tiva mixture in a bag, and that's because there is a reference for it, and it comes out of the war surgery manual, and that's where it's a bag, it's a 250 bag or a 50 cc bag or whatever bag you're going to use, and per cc, if I can remember this correctly, I believe there's 3 milligrams of ketamine and 0.1 milligram. It's either 0.1 or 0.01 milligrams of Versed per cc. So if you were to pull up a 10 cc syringe of that, you're getting, I believe, 1 milligram of Versed and 30 milligrams of ketamine. So, there you are. It's you could either put it in a mini dripper and just turn it on, and you're just, your 60 drops per second is 1 mil per minute kind of thing. Then over 10 minutes, you're going to get 1 milligram of Versed and 30 of ketamine or whatever it is, right? So, but that I do teach, and I teach that specifically because there is a reference. So that way, when they do go back to their battalion surgeon or whoever is overseeing their practice, like, okay, here's the reference out of the war surgery manual that the nerdy nurse anesthesia guy was talking about.
Sure.
So I will say there is a quick story that I can relate using that exact mixture with the bag with the ketamine and Versed mix, where it was a small team. They were training. This was like part of their initial training. And one guy was like, I'm going to start this drip. He starts the drip. Everybody else is doing different things. And the drip is way too fast. The whole thing goes in really quickly. And the guys made the mistake. We're like, it's not a a capital offense. You could go in there if they're having trouble breathing, you can bag them. But what they did is they hadn't moved to the RASS scale. So they were not using the Richmond Agitation Sedation scale. They were still using GCS. And so now they said his GCS dropped from 14 to 3. We need to intubate him right now. Oh, we don't intubate. Let's go ahead and crack him. So they were staying on that whole GCS side of things, and they hadn't made the mental jump to, okay, we're sedating him. It's a completely different ball game now.
Yes. So there is definitely a risk of putting all those medicines in a 250 bag, and the next thing you know, you turn around and you're like, that's the patient got that whole bag. Well, yep. I guess in that scenario, I would look at the patient. Are they ventilating?
Sure.
How, look at their hemodynamics and then make a decision on what to do. I don't know what was going on with the patient, but both ketamine and midazolam, their therapeutic indexes are large, right? Yep. You can give a lot of both of those medicines and be safe. I want to say, because somebody asked me and I looked up like the toxic dose of ketamine, and it was like, I want to say upwards of 7 grams. It's a lot. If you're pushing multiple vials, and we always tell people if you're using more than 1 vial, you need to check your math. And this just goes back from when I was an ER nurse, and we would get patients that came into the emergency room that had, overdosed on benzodiazepines. Typically Ativan is what we would see. And at that time, when we looked at, the toxicology data, as a sole agent, like typically yes, you're going to sleep for 4 days, but you're going to continue to ventilate and be just fine. So, yeah, did that guy need to be criked? Probably not. So, but at the same time, and I know Dennis and I have talked about this before, I try not to be a Monday night quarterback. I really do, because it's tough, right? Like especially guys downrange. Whatever scenario they're in, the context of the scenario is huge. And I think we, myself included, have to understand that. Like, you just have to understand the context that they're operating in and the decision-making processes that they've come up with. So my guess is, as an overabundance of caution, they took that guy's airway, which I am not going to, all right, did it work? Did you get the guy through it? Good. Yeah. Move on.
Yeah.
So.
It was definitely a great learning point where we had a good discussion afterwards.
Yeah, exactly. Yeah. And I think that discussion should happen amongst the people that understand the environment that these guys work in. That's huge. Is having that I guess you would call it institutional knowledge of, this is what it's like in someplace in Africa or wherever it is, in a hut, and you guys are trying to figure this out. Like, it's challenging.
Yeah. There's definitely a difference. The AARs afterwards talking to a peer versus talking to, random expert.
Right. Random expert they are extremely intelligent. Don't get me wrong, but it's the context, I think, also that plays a huge role in some of the, obviously, in the decision making process.
Yeah. Just kind of going through some other questions. So now that we have some background information, like who is the right patient? When is the right time to start using Versed?
So, and once again, I am a polypharmacist. I mix drugs all the time, right? So I have to put my own bias out there for everyone to listen to. Like, I mix drugs chronically.
Yes.
And so for me, and so specifically downrange, the times that I've given ketamine first, and I'm talking small doses of ketamine, the analgesic doses where I can communicate with a patient, anywhere from 0.1 to 0.3 mg per kg. So that is somebody that is 100 kilos. Let's just use that. It's easy math. So that's 10 to 30 milligrams. I can give that ketamine first, and then I can assess whether or not they are have the reaction that we're not looking for, which is some sort of an anxious reaction. They don't like it. The walls are closing in. They can see, they have auditory and visual hallucinations, and that's not the party dose. That's the analgesic dose, right? So, but they're having a bad trip, so to speak. I immediately go ahead and give 1 milligram to 2 milligrams of Versed, and that will usually make that anxiolytic dose, along with, in my mind, it is an amnestic dose. They calm down and then they relax. So I had a scenario the other day in the operating room where there was a procedure being done, and I put a spinal in somebody, and the spinal lasts about 2.5 to 3 hours, and we were getting towards the end of the procedure, which had taken 2.5 to 3 hours. So the spinal, I was running out of spinal, so to speak. So I had to give a medication. So I chose ketamine, and I gave 10 milligrams, and I was able to speak to the patient. The patient said, "I feel great," and then fell asleep for 10 minutes, and then woke up and was having a little bit more pain. So I gave another 10 milligrams, and then I reassessed and gave another 10 milligrams and reassessed. So in that scenario, I am able to communicate to the patient, or the patient is able to communicate to me that they are doing okay. So I did not use Versed at all. I just gave bumps of 10 milligrams of ketamine at a time, about every 10 minutes, because that's about how long 10 milligrams of ketamine lasts. And I got her through the rest of the procedure, and then that was it. We were moving on. She didn't have any bad memories. She was fine. Now, if she was having, like, she didn't like it, or she was having a anxious type reaction where she's trying to crawl off the table, well, all right, well, then you get Versed. So I think that's a staged approach. Do I need to give Versed or not when I'm giving ketamine? Now, if I would have just given her, say, 50 of ketamine, I can no longer communicate with her. She is not going to be able to communicate to me that she is not having, for a lack of a better term, I'll use a bad trip. So how do you know? You don't. You're clueless. So in that scenario, I would have gone ahead and just given 2 milligrams of Versed. You get 2 milligrams of Versed because the dose of ketamine I'm giving to you, I can no longer communicate with you. For you to tell me that you're not having you're fine. Now, you could rely on pushing 50 milligrams of ketamine or a bigger dose of ketamine, and then watching for some sort of outward signs of, like, this is not going well. Like, the patient becomes combative. Okay, yeah, that's straightforward. You can see it. Here's 1 or 2 milligrams of Versed, and the patients typically will do okay. I think if you're going to give anything above the analgesic dose, I personally, who am a polypharmacist, depending upon the hemodynamic stability of the patient, will give 2 milligrams of Versed, 1 milligram of Versed, and just go from there. That's what I do. So, but that's somebody, I give hundreds of milligrams of Versed a year. I give hundreds of milligrams of ketamine a year. Like, I just do it all the time. So I know the effects. I can see it.
Yeah. So just speaking of that kind of amnestic effects of Versed, is it kind of, obviously everything is dose dependent, right?
Mm-hmm.
But do you see like anxiolysis early and then giving larger doses, you get the amnestic effect, or are those two things intertwined?
I would say those are intertwined. So let's talk just about IV amnestics. So there's the two big ones that are in our world are propofol, and the other one is midazolam. There's a couple other ones that are out there. There's etomidate. There's other medicines and they're used in different countries, but the two big ones that I'm comfortable with are midazolam and propofol. And to say that there is a milligram per kilogram amnestic dose of either one of those it does not exist. So those are, I can't tell you that if you give 5 milligrams of midazolam that this patient will not remember the next hour. I cannot guarantee that. That's a false statement. So when in anesthesia, we use our potent inhalational anesthetics. So sevoflurane, isoflurane, and desflurane are the three big ones that we use here in the United States. At a certain end tidal percentage of gas of those potent inhalational anesthetics, I can feel comfortable that this patient is amnestic. They will not remember what's going on. They might have pain. They might have a sympathetic response to surgical stimulus, but I can say they're not going to remember this. They're not going to remember incision. They're not going to remember having their leg reduced or whatever it is. I cannot say that when I'm doing a TIVA. So when you're doing a total intravenous anesthetic, I cannot say at this dose of propofol is reliable amnestic. This dose of midazolam is a reliable amnestic. This dose of ketamine is a reliable amnestic. And ketamine is, I don't even consider an amnestic drug because you're forming memories and you're typically remembering them. So 2 milligrams for you might remember the whole procedure, like an EGD. I think where 2 milligrams for me, I might not remember the next 24 hours. So some of the things that affect the doses of these medicines are obviously the physiological state of the patient, hemodynamics. Like if you have somebody that's hemodynamically unstable, you're not going to be able to give a large dose of any medication for that matter, whether it's ketamine, propofol. I mean, obviously I don't use propofol in trauma, or midazolam, or even anesthetic gases. Like you just can't give them a lot of drug. So I start small. I give a milligram or two in a trauma patient, see how they react to it, see if I see a large swing in blood pressure, then I'm like, ooh, okay, I am way behind the power curve on resuscitation, that I need to prioritize hemodynamic stability or autonomic stability over amnesia at this point, right? But if I give a milligram or two of Versed and their hemodynamics remain the same, then I'm like, okay, like I know where I live now. I can live with 1 or 2 milligrams of Versed, and I'm still. I mean, hope is not a great method, but I'm hoping I'm making that patient amnestic.
Yeah.
And I don't know if I think that answered your question. Like, what's the dose? I don't know. There is no dose. There is no dose. And then too, like, I mean, we're all adults here. You go down range, and some guys, drink beer or drink, harder alcohol.
Not downrange, of course.
Not downrange, but we'll use our foreign partners. Like
sometimes the juice goes bad.
Yes. So the guys that are chronically consuming alcohol downrange have a much higher requirement for benzodiazepines. So, for me, that's some of the things I pay attention to as an anesthesia provider. I am watching who I am around and who are my most likely casualties, and whether or not are they drinking, yes or no. And if they are, okay, well, I put that data point in my brain. So when I do take care of that guy, I go, okay, like he still might only get 2 milligrams of Versed, but he's going to chew through that a lot quicker than, say, someone who's alcohol naive while deployed, like you just haven't drank at all. So you might have to give it more frequently, and you might have to give a bigger dose. And it's just because their enzymes are typically revved up and they just metabolize it quicker.
Yeah. So, whenever I give, any kind of narcotic, I always have a goal, an end state of I'm going to keep giving this drug until I reach whatever. With sedation, especially after you've achieved pain control, like how do you assess that you've given enough? Or is it just like you get one, you get one, everybody gets one. And that's like, nope, that's just what we give.
Yeah, so, and this is something I think any anesthesia provider will tell you this, that the cases that we find the most challenging are sedation cases. And at least I will tell you straight up, they are the most challenging cases that you will ever have as an anesthesia provider, is how to sedate somebody and keep them ventilating, but also keep them comfortable, and potentially also making them amnestic of whatever we're doing. So we do it during the week, on a Monday through Friday case scenario. Sometimes we do it, 20 times during the week. It is challenging. It is very challenging. It is probably one of the, it is, in my opinion, the most challenging anesthetic you will ever do is just a simple sedation, because it's everybody is different. Everybody requires different amount of medication. Everybody has different comorbidities that affect how much you can give or not give. It's like, how do you keep somebody ventilating, but calm and sitting still and not moving, right? So you are on a tight wire. Right. Sometimes that tight wire is you give 12.5 mics of fentanyl and all of a sudden they go apneic. Right. So human beings are not meant to lie still in the same position for hours on end. That's just not what we do. Right. So if you're asking someone that you're sedating them, essentially you're asking them to stay in the same position and not move for however long, they become uncomfortable. It's just like they're, every portion of their body that's touching the bed or whatever they're lying on is becoming painful. We're just not meant to lie still. Like it's just not what we do. Like if you think about how we sleep, we move all over the place. So how do I keep somebody comfortable? It requires all my brain power. And I have a lot of data points I'm looking at. I'm looking at respiratory rate. I'm looking at heart rate. I'm looking at blood pressure. I'm looking at the patient. And depending upon how deep or not deep you want to sedate them, do you want to tap them on the shoulder and have them wake up and they look at you and you're like, hey, how are you doing? And they're like, oh, I'm doing good. Okay, all right, we'll go back to sleep. Or like you have to get them deep enough to tolerate whatever is going on, to where you might have to perform an airway maneuver. You might have to put an oral airway in or a nasal trumpet, or turn their head to the side or do a jaw thrust. It's challenging. So what I use in the operating room is I use respiratory rate quite a bit when I'm doing sedation, right? So I look at heart rate, I look at blood pressure, but I watch the ventilatory effort and I watch the rate. As I see the rate picking up into the teens, up into the 20s, that tells me they're becoming uncomfortable because they're just ventilating faster. And all things being equal, like if you go through your differential diagnoses of like, why is this guy ventilating quicker? Like you've resuscitated them, like we're in the point of like, we're just hanging out waiting to figure out how we're going to get this guy out of here. I usually will keep the sedative medicine at a steady rate, whether that's midazolam or whether that's propofol. And then I choose to use narcotic to just drive a respiratory rate down to get them comfortable. So when I say drive the respiratory rate down, I will give 12.5 mics and then just see what it does. So if they have a respiratory rate of say 20, and I give 12.5 mics and it decreases the respiratory rate by 3 breaths, then once again, that's a data point. Then I could say, okay, 12.5 mics of this decreases respiratory rate by this. And then I'll give another 12.5 mics, and it'll decrease it by 3 more breaths. And now I'm living in the 12 to 15 breaths per minute range. That, to me, they're comfortable. That's kind of how I do it. So that way I'm not, I don't want to make them apneic, because then I've just created a problem that I need to fix. But I also don't want them becoming extremely uncomfortable, and now they're coming off the table, or they're moving around, or doing whatever they're doing, and now that's a problem that I have to fix. So I try not to get into either one of those problems, and just try to keep them in the middle of that, which is just lying still, nice smooth ventilatory effort, and I can still wake them up and just kind of look at them. Hey man, how are you doing? I'm doing good. Okay, go back to sleep.
Yep.
So grabbing that baseline before you start out, that's pretty important. So you give them a sedation before the procedure starts. This is kind of where baseline is for that person.
Yeah. And then also too, like if you're doing, say, a wound debridement, and you're trying to keep somebody sedated for that, and they start withdrawing to pain, I, as the anesthesia provider, am not providing analgesia to that patient. You, as the proceduralist, are providing the analgesia by localizing the area. So say, for example, I am in the operating room with one of my surgical colleagues, and we're doing a sedation, and the patient starts to have pain. I can give more propofol. Sure. Well, what's that going to do? It doesn't have any analgesic properties. It just makes them stop breathing, right? Okay, well, I can give them a bunch of fentanyl. Okay, yeah, that's an analgesic effect, but now I've just lost my airway, or I've just made them stop ventilating. Now I have to deal with that. Or I can look at my surgical colleague and be like, hey, can you please use more local anesthetic, because they need it. And as long as you're not getting into the toxic doses of local anesthetic, that's what they need. They don't need more sedation. They don't need more fentanyl. What they need is for you to localize the area so that's the main analgesic you're providing the patient, is the localization of the tissue down in the area that you're debriding or sewing or whatever you're doing. Up top, you're just providing some sedation so they can lie still for however many hours it's taken to do this, and provide some amnesia so they don't have to remember you scraping on their leg.
Right. I mean, and that kind of goes into my last question, and potentially you've already answered it, but none of these drugs last forever, right? They all burn off, and they all burn off at different rates. So you have a patient who was perfectly fine, and let's say, his respiratory rate starts climbing. His heart rate starts climbing a little bit. One, how fast are you jumping on this? And kind of two, how do you determine he needs more analgesic, he needs more sedation?
So if I see what I think is a sympathetic response to pain, or just in general being uncomfortable from lying still, midazolam, propofol, they do not have any analgesic properties. None whatsoever. So if you assess that this is a pain response, then in my mind, it makes no sense to give any more sedative medication. This has nothing to do with sedation, because you're still going to be uncomfortable and be in pain. You're just not going to remember it more, I guess. I don't know how else to say that. So when I see people having an increase in heart rate, increase in blood pressure, an increase in ventilatory effort due to a surgical stimulus, or just lying in bed, lying still for hours on end, that to me, most people if you give more sedative, you're getting yourself into trouble, because eventually their airway is going to become so relaxed that it's going to collapse or whatever it is. So I choose narcotic in that scenario. So how fast do I jump on it? Very fast. Because one of the things you learn when you look at, like, our job is to just monitor vital signs and the response to surgical stimulus and the response to our anesthetic medications that we're giving. And we do it if you're in the OR for 12 hours, you are literally looking at these monitors and just taking all these data points in for over 12 hours. So you get to know the patients, and you see a 3 or 4 or 5 beat increase in heart rate. That actually means something. And when you're a new anesthesia provider, you don't necessarily pick up on that as quick, and you're always behind the power curve. You're like, you don't pick up those small changes in physiology until they're about to move, or until they're about to, and then all of a sudden they move, and now you're playing catch up. Versus as you've been doing it for a while, you're like, oh, that 3-beat increase or 4-beat increase in heart rate means something. That 10-point increase in blood pressure means something. That increase in respiratory rate from 12 to 18, that means something. It means your medicines are starting to wear off. And it also potentially could mean that they're increasing analgesia. They're having a response to pain. So get on it. And if you get on it early, you don't have to give as much. But this is hard, right? Like you might have six patients, right? Like I have one, right? Without I'm doing this to. So if you're doing this to 6 patients, it is challenging. It is absolutely challenging. Like you are going to be running with your head chopped off, trying to keep all of these patients comfortable and still, and while you're doing this sedation. But very rarely, if you haven't, when we're talking about Versed and propofol, I'm thinking of an infusion, right? But if you don't have an infusion running, typically like your Versed, it's probably 1 milligram to 2 milligrams every half hour to an hour is typically pretty good. Now, if you have guys that are chewing through it, okay, well, it's going to be every 15 minutes, or it's going to be or you're going to have to increase your dose every 30 minutes. But the narcotic is the same. Like you have to stay on it, and you got to be there. And it's challenging. It's hard. Sedation is the hardest thing I do. And so I always kind of, we teach a lot of we have the United States Army graduate program in anesthesia. It's a phase 2 site at WOMAC, and we do a lot of teaching with these the folks that are in the graduate program. And they're all like, hey, let's do sedation. And I'm like, okay, let's see how this goes. Like, and they're like, what? Right? They're like, oh, this will be easy. And you're like, oh God, here we go. Right. And then it's usually a rodeo. Like, you're just like, and you get done with the case and you're like, oh my God, this was a back lipoma. And you're just you're on the struggle bus the whole time. And you're like, and then they look at you and they're like, I am never doing that again. I'm like, I know you're never going to do that again, but I had to show you that you never want to do that again.
Right.
So,
dumb question, but I think it helps with just context. When you're in the OR, are you using invasive monitoring, or you're like the, kind of automatic, like BP cuff, etc.?
So we are using, for sedation, where typically you're not using invasive monitoring. Now you might have somebody who's got significant cardiac disease or pulmonary disease, where you're going to put an arterial line in them. And you're going to still do sedation, and you're monitoring like invasive arterial pressure. But no, typically it's a non-invasive blood pressure cuff. We'll put a face mask on them for simple oxygen or a nasal cannula. But we do 100% are monitoring end-tidal CO2 because that gives us time now that the patient has stopped ventilating, versus a pulse ox, which takes a few minutes before you're like, oh, I guess they're not ventilating. So so we are 100% using end-tidal CO2 in those scenarios to keep an eye on very frequently, when in our worlds, when we lose end-tidal CO2, like everything starts alarming at you immediately, like, hey, like you need to do something time now. So cool. I think if you guys have your EMAs, and somehow I've seen, everybody does it differently. I've seen people rig EMAs into face masks. I've seen EMAs rigged, but if you can keep an eye on an EMA to make sure that they're ventilating during sedation, great. Otherwise, I don't rely on pulse ox. I rely on rise and fall of the chest, right? That's what I rely on. So, but once again, this is, you got to have good conditions to rely on rise and fall of the chest. Like if you're in the back of an aircraft or in the back of a moving vehicle, it's at night, you're under nods, like rise and fall of the chest, you can only put your hand on them and just feel it. And even then, like with the vibrations of whatever platform you're on, you're like, I don't know, is that them? Is that me? I'm like, So the EMA really is probably one of the best monitors that you have downrange that gives you a good amount of information.
Yep. It sure does. Do you have any final thoughts?
No, I just would say, I know there's a lot of kind of midazolam, there was an article that was out and that, like a staged approach to using midazolam, which I don't agree with. Which I do agree with. I do agree with using it as a staged approach, but I find it, one thing that I would say that's hard about that staged approach is if you have a patient that you've given ketamine without Versed and they are unable to communicate with you that they are having a bad experience, how do you know that they are having a bad experience?
Right.
And I would argue that you don't. You have no clue, right? So, and I know, Dennis, you and I have spoken about this, that if you are, say, for example, out playing soccer or hockey or whatever sport or, whatever it is, and you break a bone, okay, and you go to the emergency room and you got your buddies with you and they're joking around with you because you're an idiot because you broke your bone or whatever it is, and then you get your ankle reduced or your shoulder put back in and they hit you with ketamine. That scenario is much different than you are in a combat situation. Your sympathetic nervous system is firing 100% because you're in a gunfight or you're on a convoy where there's IEDs all over the place or whatever it is, or you just watched one of your buddies, get injured or killed or whatever it is, and then you're injured yourself and they're giving you pure ketamine. Your trip, whatever is probably not going to be the same as the guy getting it in the emergency room.
Yep.
And I am very biased, and I've also, and once again, I recognize that I'm bringing my own bias to this conversation because I use Versed on a daily basis. But I've also had multiple conversations. And once again, these are the lowest form of evidence. It's case reports, right? It's me talking to the guys that I've had conversations with that are friends of mine, or guys that I've just, had conversations with that have been injured downrange that have pure ketamine. I have yet to come across one of them that said they've had a good trip. Not one.
Yep.
So, and I'm assuming they're out there, but you talk to guys and they say the ketamine was the worst thing that they experienced the whole entire time. It was worse than the actual injury. So the hallucinations from the ketamine, right? And I'm like, well, did you have any pain? And they're like, well, no, but I was, having these horrible hallucinations. I was locked inside myself and I thought I was dead. Right? Like, and that they live with that for the rest of their life. They have PTSD, not from the event, but from the ketamine.
Right.
So once again, these are case reports. It's the lowest form of evidence, but it's enough for me to go, I'm going to give you 2 milligrams of Versed in hopes that you're not going to have a PTSD from the ketamine, but at the same time, I look at the scenario. If I think the guy is going to lose vital signs, do they need ketamine or Versed, or do they need, where am I at in my linear algorithm? Because I'm by myself of what do they need? So to say that, yes, Versed can cause this huge sympathectomy and you're going to lose your vital signs. It's dose dependent, first of all, right? In the dose in 1 to 2 milligrams, if you cause a sympathectomy and they lose vital signs, and I did that, I would say, man, I missed the boat. I didn't see what I should have seen to say, do not give anything, start giving units of blood, right? Is that kind of the scenario? So I guess in closing, I agree with the staged approach in the analgesic dose of ketamine. Give the ketamine in an analgesic dose, and if that patient doesn't start to have a bad trip, you do not need to give Versed. Agree 100%. But if you are anywhere above the analgesic dose, it is very hard to assess whether or not they need Versed. You have no idea. So what I do is, if I give a bigger dose of ketamine, they are going to get Versed.
Yep. I think that's smart.
That's what this guy does. How about what would you guys do? What have you done in your past downrange?
So I
Paul.
know for me, I don't pushing Versed is not something we do all the time. So a lot of times you do have to rely on the clinical practice guidelines, the case reports, and everything else, the AARs that we get from other guys. But as you were talking about that, it kind of made me think of all the stuff that's coming out with psychedelic research. And, if you're talking about ketamine being somewhat like a psychedelic, and what they're looking at prior to administration of any of those psychedelics, the setting is kind of what they're looking to optimize. Now, obviously, we can't do that everywhere, but you do hear about ketamine coaching, like, okay, imagine you're in a nice place and everything else like that. I almost see Versed here for the anxiolysis as like an adjunct to that setting. So you're trying to bring them down just a little bit before you give the ketamine. What do you think about that?
Yes, 100%. Like I do believe as an anxiolytic drug that giving that in that scenario is you're right. Like you're trying to take them out of the scenario of that they're downrange in a gunfight, and bring their sympathetic system, bring kind of that anxious feeling away. Like, am I going to die or am I not going to die? Am I going to get home to see my children? Am I going to get home to see my my spouse or whatever it is? Like, because that's what's going through, I'm sure, everybody's mind that's injured. Like, you're like, holy cow, is this it? Am I done?
Yeah.
So you give them, once again, dose dependent. You don't have to crush them. You give them a milligram and see what happens. And if they tend to seem to do better, then all right, great, move on. But yeah, agreed. I think it's very, very scenario dependent in the environment you're in. I'm pretty sure a person who's abusing ketamine is not going to, get in a gunfight and then go run home and do ketamine. Like, it's probably just not going to happen.
Yeah.
The one thing we didn't really talk about, I know we're at an hour now, but the reversal agent for Versed.
Oh, yeah.
So we haven't touched on that, but I know 10 years ago there was a case report out of South Sudan with the evacuation of the embassy where you had multiple patients on the back of an Osprey who took small arms fire. And eventually, through the evacuation chain, one of the patients was overdosed on ketamine and they had to give Ramazepam. Is there anything you would say about that before we end today's podcast?
So just real quick, just going back to your statement, were they overdosed on ketamine or were they overdosed on...
Sorry, Versed.
Okay,
yeah, thanks for
I'm
the
just
catch.
making sure. Yeah, no problem.
Yeah.
So no problem. What I would say is, and this goes back to me working as an emergency room nurse a long time ago, and we would frequently get patients that have overdosed for whatever reason on benzodiazepines, and whether that's Versed or typically we saw Ativan. I just think Ativan at the time was just people were prescribed it for anxiety at home, and then they would just take the whole bottle for whatever reason. And once again, I'm going back from my memory of almost 20 years ago. Benzodiazepines as a sole agent in a patient that has, stable physiology, the therapeutic index is huge. You do not have to reverse them, right? They will typically just sleep for 4 days, but they won't stop ventilating. They're not going to be hypotensive to the part where you actually have to do something about it. They are typically ventilating. So benzodiazepines, they do not affect. And once again, I believe this is dose dependent, but I'm pretty sure it's dose dependent. They do not affect the hypoxic drive to ventilate. So your CO2 system is not affected by benzodiazepines. Your hypoxic drive, your hypercarbic drive to ventilate is not affected by benzodiazepines. I misspoke. Your hypoxic drive is. So your hypoxic drive to ventilate does not play a factor until your O2 sats are around 90%, or your oxygen in your arterial system, your PaO2 is around 60 millimeters of mercury. The patients you get into trouble with that are like COPD patients that rely on the hypoxic drive to ventilate, not the hypercarbic drive to ventilate. So I would have to go back and really just look at that scenario. Who got the Versed? How much was it? Like, what was it? Did they have like undiagnosed sleep apnea, because patients with sleep apnea are exquisitely sensitive to benzodiazepines. Benzodiazepines on top of narcotics is you're definitely putting yourself in a bad scenario where you've now their hypercarbic drive to breathe is set at a different level, and you've given them benzodiazepines, which decreases the muscle tone in their airway. So now you're obstructed and you don't have a drive to breathe. So I think in that scenario, it depends. If I have a patient who is not, say, waking up from anesthesia, they're not emerging for whatever reason, right? So there's 3 boxes that I put this into. One of them is pharmacologic. That's a box, right? So what medications have I given them? There's gas, there's benzodiazepines, there's GABA agonists, there's narcotics. And then I have to go, okay, of that box, I'll make a list of differentials. Why are they not ventilating? We give them neuromuscular blockade. So why are they not ventilating yet? So is the gas still on? Okay, well, I can tell if the gas is still on. You just turn it off. We look at our end tidal monitor. The gas is not on. Okay, they're still not ventilating. There's no gas. How much benzodiazepine did I give? How much narcotic did I give? Did I reverse them appropriately from their neuromuscular blockade, right? So we have to reverse that to get them to start ventilating again. Did I use succinylcholine? Some people do not have the proper amount of enzymes to metabolize or to break down succinylcholine very quickly. Sometimes the succinylcholine will last 8 to 12 to 14 hours. So I have to very quickly decide, is this a pharmacological issue? Okay. Of all of those, it's most likely the narcotic. So I'm going to reach for Narcan long before I reach for Romazicon. So how we dose Narcan very differently than the patient, the population of providers that take care of people on the street. We will give like a cc at a time. We dilute the little vial of narcotic, the 0.4 milligrams, I believe it is, into 10 cc's, and then we just give a cc at a time. And then so after you've done that, so let's say for some crazy reason you make it through the whole syringe of that, and they're not ventilating yet, which typically never happens. Then you're like, okay, there's metabolic causes for them not waking up, right? Are they hyponatremic? Are they hypercarbic? Are they hypoxic? Are they, do they have low blood sugar? Like, what are the metabolic causes for people that in a coma, right? So then we have to go through all that and just make sure that none of that is a problem. And then you move on to neurologic causes. Have they had a stroke? Do they have a TBI? I'm thinking of things downrange. Like, did they, when you were taking care of them initially, you missed them that they had a pretty significant head bonk, and now they've got some sort of slow bleed in their head that now 8 hours later is a big issue. And you're looking at pupils, and then are they fixed and dilated, or is one blown? So so now back to Romazicon. I've given Romazicon, I think, twice. And you do see a little bit of a response, but nothing to where, like Narcan. Like, you give Narcan, you're like, oh, it works. Like, holy cow, like they're ventilating. Or in the emergency room where you give these huge whopping doses of Narcan, they sit straight up and they start screaming at you. I have never seen that. Well, I shouldn't say. I have like an N of 2 with Romazicon, and I've never seen it. Like, I was just like, you give it because you're like, all right, we've gone through everything else. We've done everything else, and we're still not waking up. Let's go ahead and give the Romazicon. Okay. But I would say in that scenario, I guess my question would be is, what did the patient do when they gave the Romazicon? Did they wake up? Okay, great. So, but yeah, it's tough. It's tough to, I would rule out a lot of other things before I was giving Romazicon. Let's say I accidentally injected 25 milligrams of midazolam into somebody. Okay, what did it do? Are they still ventilating? Are they doing okay? Great, I'm going to leave them alone. Or I have 50 other things I need to do. I've got 10 other patients that I need to deal with, and I don't want to be worrying about the 25 milligrams of Versed I just gave to this guy. All right, I'll give some Romazicon just to try to reverse some of that midazolam that I've given so I can go on and take care of other patients. I don't know if that answers your question. I'm not sure.
Yeah. No, that seems to be a pretty common theme, is that it's probably better just to watch ventilations and let them ride it out versus adding more complexity to the situation.
Yes. Once again, every drug, and I know we've talked about this before, I treat it like poison. Do they need this poison or not? And if how much poison do they need? Like, am I going to give them the right amount of poison for it to do what I want it to do, or am I going to give them the wrong amount of poison and now it does things that I don't want it to do?
Yep.
So just treat it like it's poison and it has the correct dose, and you just have to figure that out. And everybody's different, which is hard. It is hard to do. Yeah. And I would let your your guys know that sedating somebody is the most challenging thing for me as an anesthesia provider. I would prefer to do a general anesthetic 100% of the time than sedate somebody.
Yep. Perfect. I think that's a great spot to leave off. Thank you, Kevin. Thank you, Paul.
All right. Well, it was good seeing you guys again. Until next time, take it easy.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.